Morning, students. I think I'll finish off today in half an hour or 40 minutes because our seniors, those who are referred, they have internal assessment in the afternoon. But finished off early. Okay. Today's topic is chronic rhinosinusitis. I'll divide this last topic into clinical features, diagnostic, medical treatment in this session, and the surgical treatment in the next session. Okay. Coming to definition, what is chronic rhinosinusitis? It's inflammation of the lining mucosa of the nose and paranasal sinus. We divide into acute, subacute, chronic, and recurrent. Acute means it's infection lasting less than 4 weeks. If it is lasting 4 to 12 weeks, it is subacute. More than 12 weeks, it is chronic. Okay. When we call it as a recurrent, more than or equal to 3 episodes in 6 months, or more than, greater than or equal to 4 episodes per year with asymptomatic interval of greater than or equal to 10 days. Okay. It is more, greater than or equal to 3 episodes in 6 months. Okay. Or greater than or equal to 4 episodes per year with a asymptomatic interval of greater than or equal to 10 days. Those are the definitions. What are the types of sinusitis? You should know all the names. What is it? There are acute, subacute, chronic, and recurrent. I already told about this. And what about open and closed, depending on its dryness, whether it is unilateral or bilateral, and whether it is maxillary sinusitis, frontal, ethmoidal, or sphenoid sinusitis. Okay, whether it is single sinus involved or more than one sinus involved, or complete all the 4 sinus involved. It's called pansinusitis. Whether it is anterior group or posterior group. When we call it as anterior group, if it is frontal, maxillary, and anterior ethmoids if involved, then we call it as anterior group of sinus involved. If it is posterior ethmoids and sphenoids involved, we call it as posterior group of sinus are involved. Whether it is suppurative or hypertrophic sinusitis. Whether it is bacterial, fungal, allergic, or occupational sinusitis. What is the etiology for the sinusitis? Mostly, most common cause is rhinogenic. Accounts for almost 85%. Following any form of rhinitis. Okay, so you should ask the patient if the patient comes to you and asks about the sinusitis and all. Then you have to ask any previous history of any cold or something is there or not. Okay, and dental. What's the dental cause of sinusitis? Because maxillary sinusitis caused by mostly dental cause, like root abscess and dental procedures. Why? Because the roots of premolars and molars are almost related to the floor of the maxillary sinus. Okay. Then trauma, road traffic accidents and swimming, diving, foreign bodies, barotrauma, and iatrogenic like nasal packing, and in case of any epistaxis and even septal surgery also cause sinusitis. Okay. But the hematogenous, this one is very rare. What are the predisposing factors? First one thing is mucosal edema. Because of viral, bacterial, allergic, and irritant vasomatter and barotrauma cause mucosal edema. And even mechanical obstruction because of deviated nasal septum, polyps, and hypertrophic turbinates, and Concha bullosa, and paradoxical middle turbinate. I'll show you all these in the lateral slides. Halar cells, large bulla ethmoidalis, Agger nasi, uncinate anomalies, nasal tumors, foreign body, and nasal packing. And mucus abnormality because of Young syndrome. What is Young syndrome? What's Young syndrome? Young syndrome is sinopulmonary disease and agiospermia. Sinopulmonary disease along with agiospermia. It's called Young syndrome. Okay, cystic fibrosis, mucoviscidosis, and dehydration. And some mucociliary dysfunction like cartilaginous syndrome. What is cartilaginous syndrome? Anybody? The bronchiectasis, sinusitis, situs inversus, and ciliary dyskinesia. Okay. Then it's called cartilaginous syndrome. And viral, bacterial, allergic, smoking, pollutants, hypoxia, dry air, extremes of temperature, and even sinus. Okay. And miscellaneous causes like poor health, immunodeficiency, diabetes, nutritional deficiency. Here, important things in this slide are cartilaginous syndrome and even ring syndrome. For your entrance examination and even 2 marks question also they may ask. So, mucosal edema and mechanism obstruction causes sinus ostium obstruction. Sinus ostium obstruction cause negative pressure within the sinus. Negative pressure within the sinus. Okay. Negative pressure within the sinus leads to nasal bacteria enter into the sinus. Okay, because of the negative pressure in the sinus leads to retained thick secretions and purulent secretions. Because of sinus ostium obstruction, even hypoxia happens. Because of the hypoxia, there is a chance of vasodilatation, ciliary dysfunction, and mucous abnormality. Because of vasodilatation, there will be translation of fluids and the chance of retained thick secretion. Even ciliary dysfunction also causes stagnation, leads to retained thick secretions. In mucous abnormality leads to viscous secretion, and it leads to retained thick secretions. Finally, it leads to purulent secretions in the nasal cavity. So, picture showing normal sinus in the right one and infected sinus. You can see the edematous mucosa. You can see the edematous mucosa here. Okay. You can see the normal cilia beat in back and forth and propelling mucus and trapped particles out of the sinus here. It is cilia can become paralyzed during acute sinusitis. Sinus are congested with the mucus. Here it is a chronic sinusitis. A further damage the cilia. Okay. Further damage the cilia. The mucosalum becomes thick and scarred. Is the bacteriology involved in sinusitis. Okay, that is acute sinusitis and chronic sinusitis. In acute sinusitis, mainly Streptococcus pneumonia, Haemophilus influenzae, Moraxella, and Staph aureus and Neisseria. In chronic sinusitis, most common organism involved is Staph aureus, followed by Streptococcus, influenza, bacteroids, and Pseudomonas. Severity and resolution depends on that is open or closed sinusitis, is the involvement virulence of the organism involved and the resistance of the host and even a treatment received. What is this round structure? You can see osteometal complex, OMC. It's a 2 marks question for you because OMC involves middle meatus, middle turbinate, and even inferior turbinate and uncinate process and infundibulum. Okay. Osteometal complex is a key area for a causation of chronic anterior group of sinusitis. Okay. What is the pathological variant of OMC? Osteometal complex. You can see Concha bullosa here. See, you can see the Concha bullosa. What is Concha bullosa? Concha bullosa is a pneumatization of the middle turbinate. You can compare it with the other side. This is not pneumatized middle turbinate. Here, pneumatized middle turbinate. Okay, you can see pneumatization in the middle turbinate. See endoscopic picture showing the Concha bullosa. Paradoxically curved middle turbinate. See here, paradoxically curved middle turbinate. Actually, this convex side is supposed to be, in the normal cases, this convex is supposed to be towards medial, towards septum. Okay. In paradoxical curved middle turbinate, this convexity is towards lateral. Okay. That's called paradoxically curved middle turbinate. You can see endoscopic picture showing a paradoxically curved middle turbinate. And what is medialized uncinate process? You can see uncinate process medialization here. Okay. See the uncinate process medialization. Large bulla ethmoidalis. You can see asterisk mark showing large bulla ethmoidalis, and even here inferior turbinates also hypertrophy is there. Okay. What is Haller cell? Infraorbital cell. This is called Haller cell, is also called as infraorbital cell. See, this is the orbit. Below that cell is called Pneumatoid cell is called Haller cell. What it causes? Chances of maxillary sinusitis. Agger nasal cell. Agger nasal cell, anteriormost ethmoidal cell. You can see Agger nasal cell here. Okay, blocks the frontal sinus mainly. And even nasal septum spur. This is the septum. This is the spur. This is supposed to be in the center. It bends on the right side, curved right side, and there is a spur on this right side. You can see endoscopy picture showing the spur impinging on the inferior turbinate, the right side. Okay, it's a septum spur impinging on the right inferior turbinate. And mucosal disease involving all the maxillary and right side ethmoid mainly. Okay, so what are the symptoms of the sinusitis now? Okay, first symptom nasal discharge, that either it is mucoid, purulent, or blood stained, and nasal obstruction with hyposmia or anosmia, and headache or facial pain, cheek or eyelids congestion or swelling, and hawking, sore throat, and cough, and earache associated eustachian tube dysfunction, and fever, malaise, and body ache. How do you locate the facial pain? Okay, it's very important. So if it is maxillary sinusitis, the facial pain locates to mainly cheek. Okay, and that increase on bending forward. If you ask the patient, to bend the head, if the patient complaining of aggravation of the pain, most probably because of the maxillary sinusitis. Okay, that increase on bending forward. Okay, and frontal sinusitis of location of the facial pain forehead that increase during morning and decrease by the late afternoon. It's called periodicity. Periodicity of the sinus. Periodicity is a characteristic feature of frontal sinusitis. It's located to the forehead that increase during morning and decrease by late afternoon. That's why it's called office headache. And these are the entrance exam. Office headache is also an office headache present in the frontal, maxillary, sphenoid, or ethmoid sinus. It's a frontal sinusitis. Periodicity present in which sinusitis? Like that, they may ask you. Okay, even in Viva also. In anti-ethmoid, location of the facial pain in the nasal bridge, in periorbital, and that increase with the eye movements. You should remember this one. Okay. No need to buy hard because ethmoids are just middle to the orbit. That's why the sinus involved here are ethmoids. Okay, increase with the eye movement. Post ethmoids are retroorbital pain. Okay, and sphenoid, there will be this also a question for you. Vertex pain in the vertex and even occiput and retroorbital. Sphenoid sinusitis cases. What are the signs of the sinusitis now? If it is congested in edematous nasal mucosa, this is an important sign. And nasal discharge in anterior and posterior rhinoscopy. If it is a discharge is present in the middle meatus, that is because of frontal, maxillary, and anterior ethmoids. If the discharge is there in the superior meatus, because posterior ethmoids and sphenoids, because posterior ethmoids opens into the superior meatus. Okay, into the middle meatus, frontal, maxillary, and anterior ethmoids will open. Okay, sphenoid sinus opens into sphenoethmoidal races, and whether it, any para-nasal sinus tenderness present in this important sign, and there is a post-nasal drip and granular pharyngitis. The patient complaining of pain in the throat while examining, if there is any granular pharyngitis, we can suspect even sinusitis also in the patient. Okay, and cheek swelling in maxillary sinusitis, and lid edema in ethmoid and frontal sinusitis. Okay, the Para-nasal sinus tenderness. How to elicit the Para-nasal sinus tenderness? Okay, it's in maxillary to palpate over the canine fossa. Okay, here canine fossa. If it is in anterior ethmoid, palpate medial to the medial canthus. Medial to the medial canthus. Okay. Okay, like this, medial to the medial canthus like this. Okay, if it is frontal, palpate over the floor of the sinus here, palpate over the floor of the sinus like this. Okay, don't compare, don't confuse with frontal and ethmoid tenderness. Okay, eliciting the frontal and ethmoid sinus. In frontal, have to palpate over the floor of the sinus. Okay, in anti-ethmoids, have to medial to the medial canthus. You can't elicit a sinus, sphenoid sinus tenderness because posterior. See the diagram showing maxillary sinus elicitation of maxillary and frontal sinus tenderness. Okay, what is trans-illumination test? This was only for theoretical purpose. Practically, I think nobody is doing now. Okay, what is sinus trans-illumination test? You should perform it in dark room. High intensity light source placed inside the patient mouth against the cheek in case of maxillary sinusitis. I showed the diagram. Around the medial aspect of the supraorbital ridge in case of frontal sinus. Okay, this is for maxillary sinus. This is for frontal sinus. Okay, the trans-illumination is normal. Okay, then it is a there is no sinusitis. If trans-illumination is absent, then you can suspect sinus filled with pus. Trans-illumination is dull. It's an equivocal result. Okay, I have to do the next after for 1 week or 2 weeks after antibiotic course. Okay, this is a sinus trans-illumination test only for theoretical purpose. You can tell. Okay, postural test. This also not doing. It's performed in acute sinusitis. If the pus cleaned in supine position, if the patient is supine position, you have to clean the pus. And if the patient sits upright, okay, the patient sits upright, and if the pus appears, most probably the sinus involved are frontal or ethmoid sinusitis. If the pus appears on stooping forwards like this, then it might be from sphenoid sinus involvement. And if there is no, if they cleaned the discharge and patient lies in lateral position with the affected side up, then again pus appears, means most probable cause is maxillary sinus. What are the criteria? The Rhinosinus task force criteria, major and minor criteria. They may ask you in Viva, what are the major criteria for chronic rhinosinusitis? Okay, major criteria: facial pain or pressure, nasal obstruction, nasal discharge or discolored post-nasal drip, hyposmia or anosmia, purulence on examination, and fever in acute sinusitis. The minor criteria includes headache, fever, halitosis, fatigue, dental pain, cough, ear pain or pressure or fullness. The presence of 2 major factors or 1 major plus 2 minor factors, you can suspect sinusitis. Okay, 2 major or 1 major plus 2 minor. What are the investigations rule out sinusitis? Important ones are diagnostic nasal endoscopy and maxillary sinoscopy not doing much, but X-ray PNS okay, and even ultrasound also not at all doing, and CT scan PNS is very important. MRI also in severe cases we can get that MRI scan done very rarely. Okay, and allergic tests, proof puncture or antral wash for maxillary sinus, and swab endoscopic microscope for culture and sensitivity, and fungal culture of cheesy nasal discharge. This is the important diagnostic nasal endoscopy. Okay, first pass, second pass, third pass. I think I told these things and showed you on video also. Okay, patient. What is the indications for this diagnostic nasal endoscopy? Patients not responding to the medical therapy. Is an anatomical factor preventing the adequate examination by anti-rhinoscopy, and the collection of pus from the hiatus seminaris for culture and sensitivity, and objective monitoring of the patients, and perioperative nasal inspection and cleaning. You can see the pus in the middle meatus here. So middle turbinate. You can see the pus in the middle meatus while doing DNA. It's a sinoscope, maxillary sinoscope, not doing much, but you should know how to do that. Sanitary sinus wall, sublabially, anti-sinus wall perforate directly in canine fossa between roots of third and fourth teeth with maxillary sinus trocar and cannula. Trocar is removed and sinoscope is introduced to the cannula. These X-rays are important for viva and even entrance examinations. What's the Waters view? Waters view is occipito-mental view. It's mostly useful for maxillary sinusitis. Okay. Caldwell's view or occipito-frontal view, mainly for frontal. They may ask you like frontal sinusitis best X-ray X-ray pattern is either occipito-mental or occipito-frontal. They may ask lateral or even basal view. Okay, the best view for frontal sinusitis is Caldwell's view, that is occipito-frontal. Okay, and even occipito-frontal you look for ethmoids also, and but main important one for ethmoids is lateral oblique, Reese view. The names are not much important, but you should know occipito-mental view, occipito-frontal view. Those are Waters view and Caldwell's view. Okay, and even basal view is mainly useful for sphenoid sinusitis, that's segmento-vertical. Okay, what is the occipito-mental view with open mouth? That's called Pierre's view. Pierre's view. That's useful for sphenoid sinusitis. Occipito-mental view. That's routinely we'll call it as a modified Waters view. Okay. The occipito-mental view with open mouth is called Pierre's view, useful for sphenoid sinusitis. If it is air fluid levels are there, you can suspect it is acute sinusitis. If it is a mucosal thickening is there, you can suspect it is a chronic sinusitis. You can see the air fluid level in the maxillary sinusitis. Okay, so acute condition, and in the chronic condition, you can see the mucosal thickening in the periphery of the sinus wall. So frontal sinus showing a haziness here. Pierre's view. Okay, Pierre's view I told you now. Occipito-mental view with open mouth for sphenoid. Lateral view and basal view. Lateral view and basal view for sphenoid sinus. This sonography is not much important. You can just note down just. Para-nasal bony interval is seen in hypoechoic line. Maxillary cavity filled with air appears as hyperechoic, hence posterior sinus margin is not seen. Fluid in sinus, cyst and mucosal thickening are hypoechoic, so posterior sinus margin is visible. This is very important investigation for sinusitis, that is CT scan. Okay, you can see here right side maxillary sinus is opacified, and this is the orbit. Okay, the left side is okay, it's well pneumatized. Only right side is opacified. You can see right side sinusitis, ethmoid, even ethmoids also involved here. Okay, right side ethmoids involved, and a little bit of maxillary sinus also involved, and even left side also mucosal thickening is there. Okay, you can see frontal sinusitis here. See frontal sinusitis. This right side frontal sphenoid sinusitis. You can see the sphenoid. This is sphenoid sinus. This is the intrasinus septum. You can see the haziness only in the right side sphenoid. See, CT scan will get either coronal or axial cuts, even plain with or without contrast. Coronal mass should be cut off minimum 4 mm or less than that. Okay. What are the indications for CT scan in PNS? In recurrent, acute, or chronic sinusitis not responding to the medical therapy, and before endoscopic surgery, you should get this CT scan done because it's useful like a road map. Okay, it's very important before going to the surgery. And impending complications of sinusitis, any complications of sinusitis, you should see what are the structures involved and all. That's why CT scan is very important preoperatively. The MRI PNS is very rarely will get it done. That if any complications or you got severe infection, then you will go for MRI. Okay. Then what is the medical treatment here? Mainly systemic antibiotics and nasal decongestants, antihistaminics, analgesics and anti-inflammatory drugs, and medicated steam inhalation and nasal douching, and mucolitis like ambroxyl, and anti-allergy treatments, and very important, heart fermentation. These are the medical antibiotics like amoxicillin clavulanic acid, Cipro, Doxy, Cefadroxil, Cefaclar, or cephalosporin, cefuroxime, third generation cefixime, cefuroxime, and azithromycin and clarithromycin. We actually in our department will write for sinusitis mainly clarithromycin, azithromycin. Okay. Antihistamines, they show very good improvement with this clarithromycin. Okay. What are the antihistamines will use? Like cetirizine, fexofenadine. Fexofenadine, loratadine are less sedative. Okay. Levocetirizine, disloratadine, and spray like elastin spray. What are the decongestant, nasal decongestant will use? What are the systemic decongestants like phenylephrine, pseudoephedrine, and topical decongestant like xylometazoline, oxymetazoline, and saline drops. Okay. What are the anti-cold preparations like codeine, Aldin, Senarest, Decold, Suprin, and all. Okay. The topical decongestants includes oxymetazoline for nasi and adult, and oxymetazoline pediatric, nasi and P, xylometazoline. Okay. And saline drops. Okay. These are topical decongestants. What is the fungal sinusitis now? It's important. Actually, for postgraduates, is a very important question. For undergraduates, also they may ask you in a sinusitis essay, they may give you. Then you have to write all these things. Okay. What is fungal sinusitis? That is invasive or non-invasive. In invasive, IFA present in submucosa. Okay. Whether it is acute or fulminant, chronic or indolent. If it is acute, it is less than 4 weeks duration. Chronic, it is more than 4 weeks duration. Okay. The non-invasive means the allergic, fungal ball, or saprophytic. Okay. This non-invasive also is very important for your questions and even entrance exam also. Okay. So Aspergillus and mucormycosis are common for this fungal sinusitis. Acute conditions like acute invasive fungal sinusitis, usually by mucormycosis. What are the predisposing factors involved here? Immune compromise like AIDS, lymphoma, cytotoxic drugs, chronic use of steroids, aplastic anemia, and insulin-dependent diabetes mellitus, long-term use of broad-spectrum antibiotics. What are the clinical features here? Unilateral nasal discharge with black crust due to ischemic necrosis. Cerebral and vascular invasion present. Okay, absence of significant inflammation. It's an acute condition. Okay, you can see the black crusting here. Treatment: remove the precipitating factors. Important. Diabetes and treat. Surgical debarment of necrotic debris, and antifungal drugs like amphotericin B infusion for 1 to 2 months. Traconazole 100 mg BD for 6 to 12 months. And then what's a chronic invasive fungal sinusitis? More than 4 weeks in 1 week. Okay, here significant inflammation with fibrosis and granuloma formation. Here the locally destructive with minimal bone erosion. Treatment is debridement followed by antifungal agents. See the surgical debridement. Okay, coming to invasive and non-invasive. Okay, invasive conditions over, acute and chronic over. Now non-invasive conditions like allergic fungal sinusitis. It's associated with ethmoid polyps, asthma. Okay, a unilateral thick yellow nasal discharge with mucin, eosinophils, and Charcot-Leyden crystals present. The CT scan report will be radiopaque mass with central area of hyperdense due to IFA. The treatment: surgical debridement, antihistamines, and steroids. Here I want to tell you some little bit important things. What is Bent and Kuhn criteria of allergic fungal sinusitis? Okay, some 5 factors are there. Main one is polyps. First factor is polyps, Bent and Kuhn criteria. Second one is type 1 hypersensitivity to the fungus. Okay. Third one, allergic mucin. Fourth one is positive fungal culture or stain. Positive fungal culture or positive fungal stain. Okay. And fifth one is characteristic CT findings. These are 5 important. There's a Benton-Kuhn criteria of allergic fungal sinusitis. Okay, what are the characteristic CT findings? There will be radio opaque masses will be the radio opaque densities in the CT scan. Why? Because why? What is the cause of this radio opaque mass in the CT findings? Because of this allergic mucin. Because of the allergic mucin, iron and manganese gets deposited in this allergic mucin, leads to this hyperdense lesions. Okay, radio opaque hyperdense lesions. Okay, this is important for your viva. This allergic fungal sinusitis is more common in sphenoid sinus. Okay, you can see the diagram showing allergic mucin and fungal sinusitis. Okay, allergic mucin, fungal sinusitis is a removed specimen. You can see the DNA picture fungus. Okay, allergic fungal sinus, the nose. The CT scan coronal cut showing the haziness on the complete one side. Here also same picture. So axial cuts showing the allergic fungal sinusitis. Okay, on one side. Then fungal ball. Fungal ball or mycetoma most common in maxillary sinus. Okay, it's a refractory sinus with foul smelling cheesy material maxillary sinus. Treatment by surgical removal, and there is no need of antifungal drugs here. Saprophytic fungal sinusitis seen after sinonasal surgery due to proliferation of fungal spores on mucous crust. Treatment by surgical removal, and here also there no need of antifungal drugs. This is regarding sinusitis, chronic rhinosinusitis, clinical features and etiology, clinical features and medical treatment. I'll tell the surgical treatment part in the next topic, and even complications also. Okay. And here I want to tell some important points for you. Which sinus? What is the first sinus developed in birth? Which sinus develops first after birth? First one is maxillary sinus, followed by ethmoids, followed by sphenoid, followed by frontal. Maxillary, ethmoid, sphenoid, followed by frontal sinus. Okay. Most common cause of sinusitis in adults means maxillary, followed by frontal, followed by ethmoid, followed by sphenoid. Okay. Most common means maxillary in adults. If it is in children, you can tell ethmoid sinusitis. Okay. Most common sinusitis in adults, it is maxillary. Most common sinusitis in pediatric people less than 3 years, it is a ethmoid sinusitis. Okay. These are the important points for your exam point of view. And surgical video also I'll show in the next class. If any doubts, please let me know. When is the internal? Thing is not decided. We'll let you know. Okay. We'll give you time. Don't worry. Okay. Anything? Okay, then I'll finish it off today. Okay. Thank you. అయిపోయింది చాట్లో కూడా అడిగాను వాళ్ళు చెప్పారు ఆన్సర్ చెప్పాను స్టాప్ షేర్ చేస్తాను